Good evening, everyone, and would like to thank you for joining our meeting today. This is Shakir Awsam Hadana, Senior Diabetes Educator at Sheikh Shakhbout Medical Hospital. I'm dealing with pediatric and adult endocrine patient, and we see also other endocrine like growth hormone deficiency and other endocrine patient. And I'm happily joining you today to coordinate the meetings. And today our meetings is about maximizing the clinical outcome with CGM. We have two speakers, Dr. Ali Diabat and Ms. May Abu Jalala. And this is our third meeting for Diabetes Educator Society Voice. And we will have more meetings and webinars coming across the line. And now it is my pleasure to welcome Dr. Ali. He is a consultant of endocrinology with over 2 decades of clinical experience in UK and Middle East. He holds also PhD from Newcastle University and fellowship from Royal College of Physicians, London and Edinburgh. As his pioneer in advanced diabetes technology, he's a perfect expert to guide our discussion today. Please join me in giving a warm welcome to Dr. Ali Diabat. Dr. Ali Diabat, the floor is yours.
Thank you so much for the kind introduction and a very heartfelt thank you to the Society for inviting me and to Zainab for inviting me for this evening. And I hope what I will share with you will be relevant and useful to you all. I'll share my screen now. So what I will share today with you, probably some of it you already know, but the idea is to bring some practicalities to where we have come across since the beginning of the glucose sensing revolution. So we'll talk about the technology, we'll talk about how it kind of is integrated in our kind of day-to-day life, where we support patients living with diabetes to find the best treatment. And I will start with you with this video. And I want you kind of to think of our patients who are living with diabetes who are driving blindly. And whenever they want to see their glucose, they do this. And as you know, driving is dangerous stuff. And if you don't see in front of you, you are likely to do accidents. Sadly, our patients living with diabetes have lots of accidents. They have hypos, they have highs, they develop like even neurological changes related to that. They develop hypoglycemia and awareness, or they become like very accustomed to high glucose that when they are in normal glucose, they just start to feel the hypoglycemia symptoms despite being in the normal level. So this is where they get a window of their glucose by pricking their finger. And imagine someone who is driving, pricking their finger every 5-10 minutes. That's how they can do it safely, but that's how painful it can be. Now you can see here, when CGM came about, it enabled that insight about the glucose changes. Maybe not perfect, but it is truly a revolution. When you are driving without being able to see, you are likely to do accidents. When you see, we still do some accidents, but the likelihood of that will be significantly less. And that's the idea from CGM, is to give you insight about the hidden spots, about the blind spots that you live with. So this is like the blood glucose monitor of someone. You must have come across something similar like that. It's variable. Some readings are in target, some above, some below. And this is like when we do the CGM. And if you overlay them, you start to see certain patterns. So there are peaks which were not detected, and these peaks are hurtful. They hurt the blood vessels, they hurt the nervous system, they hurt the kidneys, the eyes. And also there is variability that is not detected. And as we know, variability is associated with worst outcome related to diabetes. And now it is a marker, a readout in the CGM. And also you get silent hypos, which are not otherwise detected, where glucose meters just detect one snap point, where now we can have a full line of travel of glucose by having the CGM. Now, how does it work? There are obviously different technologies to it, but the core principle behind it is checking the glucose in the interstitial fluid. And we have come across long way. I mean, in the old days, we used to have a sensor and then a transmitter over it, and the transmitter need to be charged in like daily, and then every 3 days, and then 6 days. Then we have like the 10-day, 15-day, and soon there are some clinical trials on some 28-day sensors, and there are sensors that are implanted for a whole year. And the principle here is glucose oxidase. When the filament is in the interstitial fluid, we get like a reaction between the glucose and the glucose oxidase, generating a current. This fine current goes to the a processing unit, which is then converted into a glucose reading. And this is very clever. It happens by the minute. And different technologies work differently. Some of them report it every 5 minutes, some of them report it every 3 minutes, some of them report it every 1 minute. But nevertheless, we get that stream of data continuously. But at the same time, we are checking interstitial fluid, not the blood glucose. And as we know with osmosis, it takes time to get equilibrium between blood glucose and the interstitial fluid. That's why we always have a degree of delay. So when there is no food, your blood glucose and your sensor probably are okay in tandem with each other. But then when there is a fast change, that's when the difference between the sensor and the glucose in the blood are different. And that happens when we are exercising, or when we are eating, or when we are stressed and there's something that's pushing our sugar from inside. And this is one of the advances that some of the providers have, is when they start to develop algorithms that can predict those changes and compensate for them, to bring the accuracy as much as possible to the blood glucose readings. And soon, in the not far future, we will have continuous blood glucose monitors, not continuous glucose monitors. Those are implantable sensors that go inside the body, similar to the pacemaker, but inside the blood vessel, that will give us actual blood glucose. And that will be a truly awesome revolution once we have it. Now, what's the difference between blood glucose and the CGM? In principle, we mentioned it. Apart from the pain that you get from the finger prick, apart from the blind spots that you have all the time that you are not pricking yourself, and also apart from the lack of alarms with blood glucose, it is still a useful tool and the most accurate tool that we have in terms of kind of home glucose monitoring, because it checks the blood glucose. So it's not obsolete at all. And in my opinion, it complements still the continuous glucose monitors that we have. But it is really awesome with the glucose monitors, because you get a stream of data about the glucose as if it is like a movie instead of a picture. The picture captures one moment in time, but the movie tells you the whole story. So you know that what's happened overnight, you know what happens after meals, whether the meal is good or bad, whether the exercise you've done was, a high intensity anaerobic exercise that pushed your sugar up, or whether it was an aerobic exercise that resulted in burning glucose and pushing it down. And that insight is invaluable for patients living with diabetes when they want to do exercise, because they can hack it, they can use it to their advantage. If someone is starting their exercise with high glucose, they can start with aerobics to burn that glucose. But if they are starting with low or normal glucose, they can do a little bit of an aerobic high intensity exercise to push the sugar up. But that insight, they need to know about it. They need to learn it so that they can use it to their advantage. in addition to a number of new readouts that become standard of care for assessing glycemia for patients. Again, what is kind of the complementarity and the difference between CGM and HbA1c? HbA1c tells you you can do it like standardized. Wherever you go around the world, you get the same HbA1c technology. So it's IFCC. It's supposed to be exactly the same. If you take a blood sample and you send it to 3 different labs, one in China, one in UK, one in the US, you should get the same result. But also it measures an average glucose over the past 3 months. It tells us how that average has been, but it has its shortfalls. It has been the gold standard for clinical trials, and therefore it has been linked to outcomes like the reduction of mortality, morbidity, cardiovascular disease, microvascular disease, and neuropathy. So it has been linked to all those outcomes. CGM has been with us not for as long, and therefore like the outcome link is being built up now. And I will not be surprised in the future where like that will be the main standard of assessing a treatment outcome in the future. It is affordable. HbA1c is really affordable. It's not that expensive compared to CGM, but it is a proxy. It's not a direct glucose measurement. It's how much glucose is stuck to hemoglobin. And that comes with its own faults because some people have hemoglobinopathies where the glucose does not get stuck to the red cells. And therefore, when you do HbA1c measurement, you get a false low reading. And we had really sad stories about patients losing their kidneys being assessed for their glucose, and the HbA1c appeared to be near normal when they had that hemoglobinopathy and their actual glucose has been very high. And therefore that resulted in more lenient treatment by the physicians, leading to complications. However, CGM provides the glucose, although it is interstitial glucose, but it provides the glucose nevertheless. It provides insight about hyperglycemia. It provides insight about hypoglycemia, where HbA1c does not give you that easily. Only in extreme cases you get it, like if HbA1c is too high, the patient is not having good control, or the HbA1c is too low and they are on insulin, you get worried about recurrent hypos. But those recurrent usual ones will not be picked up with the HbA1c, but CGM will enable you to see that. It tells you glucose variability, but HbA1c cannot give you that. And also it identifies trends, especially after certain circumstances, like after certain foods or after certain exercise or around the period for the ladies. So the insight that you get from it is amazing. Again, it does not replace HbA1c, it complements it. And as you can see now, we are getting a lot of tools that we can use to help us provide the best support for our patients to live as normally as possible with less complications as possible, improving their quality of life. And we all heard about the time in range being the main, the times in ranges, different ranges, being an important readout for our patients. And we can get that only with CGM. And it has been standardized. AGM, or ambulatory glucose profile, has been standardized across the board in all devices. And thankfully, we have many devices that has been entering the clinical arena for use. And it is how much glucose we spend in 24 hours in each segment of the glucose measurement. So 70 to 180 milligram per deciliter is considered as the gold standard for time and range, and we should aim for 70% or more. But I'll give you a little bit more on those targets later. And above target should be less than 25%, and below target should be less than 4%. And very low hypoglycemia should be certainly zero if we can, but we should aim for less than 1%. And only CGM can enable us to do that. Finger prick certainly cannot. Okay, so we need to be careful about the interferences. Obviously, the glucose meters use different enzymes, and those different enzymes can by mistake get either blocked or get activated by different materials, by different things that we can consume or have. For example, vitamin C. Vitamin C can falsely give high or low readings depending on the glucometer. Again, if you have low hematocrit, if you have anemia, or if you have polycythemia, if your hemoglobin is high, again, you may get a false reading there. Galactose and maltose and xylose, all of them can affect the amount of glucose in the reading, so it may give false reading. It's important to know each device we have, which device we give to our patients, about the interferences that it may have. CGM is not immune from that as well. So, for example, Dexcom with high acetaminophen, which is paracetamol, can give high readings. My understanding, this has been modified significantly and it is less prone to those interferences, but interferences are still there nevertheless. The Medtronic sensors are more prone for acetaminophen, for paracetamol interference. Freestyle Libre seems to have a weak spot for vitamin C, ascorbic acid. So the earlier generations had more effect on the lower dose of vitamin C can affect them, like 500 milligrams or more, can affect Freestyle Libre 2 and 3. But the newer generations with the plus can tolerate up to 1000 milligrams. So patients who take a lot of vitamin C, and you can see that with IV drips, or those who take a lot of tablets, vitamin C tablets, they can get a higher reading there. Hydroxyurea, which is a treatment for polycythemia and certain other blood conditions, can affect Dexcom and Medtronic sensors. Mannitol and sorbitol can affect the Eversense sensor, which we don't have yet, but hopefully we will have it at some stage in the not far future. This is an implantable sensor that lasts for a year under the skin, and it relies on an external device for charging and transmission. So the other thing about the sensors is the real-time versus intermittently scanned. And the intermittently scanned, from that class, we had the Freestyle Libre, but that kind of evolved to have both technologies where you can scan the sensor, and also you can have the real-time stream of glucose data. But probably it's the only one where you need to scan, or you can scan if you want to get a reading at that moment in time. But in terms of the real-time, like the Sibionic, the Dexcom, you get like a continuous flow of glucose all the time, and the newer generations of Freestyle Libre also do that as well. We'll get to some of the evidence. So the evidence has been building up, and I don't think we need a lot of discussion to show the value, the clinical value of sensors. The very fact that it improves the quality of life is a huge value that we can offer to our patients, but nevertheless, it can improve control, especially from a hypoglycemia point of view. So in the switch trial, there were patients who were given a sensor which was switched off and a sensor which was on. And when they were on the sensor, when the sensor was on, they clearly had better glycemic control. And then they had a washout period where the sensor was removed. And then those who had the sensor off, they switched it on and they clearly started to have better control. And I'll just put the laser. And those who had the sensor on and had good control, when they switched it off and removed it, they lost that control. So basically, they had the insight, and that insight gave them action point to protect themselves from hypoglycemia, but also to improve their glucose. The Diamond study was done on patients with A1C around 8.6%. And they were randomized to CGM or usual care. And that also resulted in a drop in A1C by 6 millimole per mole, and also which is about 0.6 percentage points, and also a drop in hypoglycemia. The GOLD trial similarly resulted in a drop in HbA1c. When people were given the sensor, they had a drop in HbA1c, and when the sensor was removed, they returned to baseline. Those who were on control, the standard glucose, self-monitored blood glucose, when they had the sensor, they had an improvement. So it's a clearly repeated kind of pattern where when you get the insight, you get the improvement in diabetes control. And the evidence has been building up. We know in type 1 diabetes, we can reduce diabetic ketoacidosis. We can certainly reduce the number and intensity of hypoglycemia, not obliterating them completely, but reducing them significantly. Probably the only treatment that works on completely removing hypoglycemia is islet cell transplantation. But for someone who's getting recurrent hypos and totaling their cars and putting themselves and others in danger, this is a huge step forward. Also, it results in reduction in coma related to diabetes and hyperglycemia. And we get from real world data similar outcomes as well. This is a summary of the HbA1c reduction. The blue ones are in type 1 diabetes. Many clinical trials showed varying results in reduction in HbA1c, and similarly in type 2 diabetes. And in fact, you get a little bit more pronounced benefit in type 2 diabetes because part of it is behavior and the insight. When you eat something that results in a spike, it conditions you to avoid it or to take more treatment for it, so that it enhances your approach to managing your day-to-day lifestyle in a way, and therefore having better outcome. So it's almost 1.5% reduction in A1C in some of the clinical trials. And in the elderly, certainly there has been a reduction in A1C as well. And this is with regard to hypoglycemia. Certainly in type 1 diabetes, although the earlier generations of CGM were not very accurate and they were not able to reduce significantly hypoglycemia, but the most recent reports have been very clear. There is a significant reduction in hypoglycemia, whether that is measured as time in range or whether that is measured as an event. Certainly there is a reduction in hypoglycemia. Same for type 2 diabetes. There is benefit, although not all the clinical trials reported, because not all of patients with type 2 diabetes are treated with hypoglycemic medications. They are on glucose regulators most of the time. So as a readout, it's mostly reducing time above range and increasing time in range. And some of the clinical reports, which include type 1 and type 2 diabetes, again confirm the reduction in hypoglycemia. And clearly in the elderly, there is a consistent benefit in reducing hypoglycemia. Well, those are kind of some of the landmark trials. The Diamond trial that I've shown you earlier, the Concept trial, which was done in pregnancy in type 1 diabetes, which resulted in less low for gestational age babies and shorter admission to neonatal ICU. And that was a truly practice-changing clinical trial that advocated for type 1 diabetes patients to have CGM during pregnancy, which is now a standard of care, but at the time that was the trial that changed the practice. Similarly, in the elderly, people above age of 60, resulting in less hypoglycemia. And as we know, in the elderly, if you reduce hypoglycemia, I mean, in all ages, you need to reduce hypoglycemia, but in the elderly, you reduce morbidity and mortality, because just a fall results in a fracture, and a fracture is almost a death sentence for the elderly. So where is it indicated? Obviously, it's indicated in all type 1 diabetes patients. When there is insulin treatment, you should give CGM. And type 2 diabetes patients who are on insulin, they should be given CGM. And this is a grade A evidence. but also type 2 diabetes who are not on insulin, but their glucose is not well controlled, they should be given also CGM. And in certain cases, the evidence is emerging. For example, in prediabetes, where patients have a chance to prevent diabetes from their glucose from progressing into diabetes, having that insight can change practice, can change day-to-day life, change lifestyle to the better. And we've seen it many times in practical clinical practice. Use in hospitals also, that's kind of growing evidence, and there are some guidelines around that, and use in pregnancies and including gestational diabetes and pediatric populations. So for the targets, in pregnancy, I'll show you the targets in a second. So in pregnancy, it varies. So if it is type 1 or type 2 or gestational diabetes, but the more time you spend in range, the better the outcomes. And it goes from 63 and above, because in pregnancy, slightly lower glucose is acceptable. In general, it's less harmful to baby, but hypos are harmful to the mother in general. In hospitals, as I've mentioned, it's the evidence is accumulating, and FDA has given G6, G7 clearance in 2023 for hospital use. And those are the targets. So in type 1 diabetes, we should, and in adults, we should aim for 70% time in range between 70 and 180, and less than 4% in hypoglycemia. Variability should be less than 36% of coefficients of variance. In type 2 diabetes, similarly, but in children, they should spend 70% of their time in range, but time in tight range should be 50%. This is another kind of a new readout, type in tight range of 70 to 140. In the elderly, certainly the most thing that we need to avoid is hypoglycemia. So time below range should be reduced to the minimum, less than 1%. Even if this means an increasing of time above range to up to 50%. And in pregnancy, in type 1 diabetes, understanding the complexity of that, time between 63 and 140 is up to 70%, type 2 diabetes 80%, and in gestational diabetes up to 90%. And that goes with that, the time above range up to 30% in type 1, 18% in type 2, and 9% in gestational diabetes. Hypoglycemia need to be kept to the minimum as much as possible. So CGM helps with exercise as well. And as I've mentioned to you, understanding how the behavior of glucose in exercise changes can be to the advantage of patients, and it helps them kind of be safe, practice exercise, enjoy it, and be safe. For example, if someone is suspecting they are having hypoglycemia and they see the trend is coming down, the very fact of tensing their muscle as if they are holding something heavy, then can push their sugar a little bit to give them enough time to go and have something sugary. Sprinting will push their sugar up. If their sugar is too high, they can concentrate more on cardio to bring it down as well. The most recent recommendations by the ADA has been truly awesome. And now they're recommending CGM from the outset of diabetes, which is what it should be. And at the time of diagnosis or thereafter, and this is across the board in children, adolescents, and adults. And it is advocated when there is insulin therapy in type 1 and type 2 diabetes, but also when there is a treatment that can result in hypoglycemia, the likes of sulfonylureas or methylglenides. And at any time when there is, the glucose control is not good and we don't know what's happening, it helps us a lot to troubleshoot what is happening and improve care. And we should ask our patients who are on insulin to use the sensors continuously rather than on and off. Patients on type 2 diabetes, they can use it on and off if they are on regulators of glucose, as I've mentioned earlier. But those with type 1 diabetes or treatment with insulin and at risk of hypoglycemia, they should use it to the maximum possible. Also, the new guidelines recommend the treatment for skin reactions related to the stickers, the adhesives of the sensors. And this is interesting because if you want to give like a steroid cream or any barrier films or antihistamines, that is kind of advocated in the guideline now. And also, it advocates for understanding the interfering substances that can affect the quality and accuracy and trustworthiness of the readings. So the takeaway messages, I mean, I don't think I need to convince you of the value of CGM, but what I think we need to kind of be aware of is how we can integrate it in a seamless way, so that patients, understand it as a standard of care, and how to make the maximum of it, how to understand it correctly, and how to use it to their advantage. We need to understand how to interpret the readings, and this is kind of your role in teaching the patients on how to interpret the readings that they get from the sensors, and how to use that to their to inform treatment decisions and actions that they do. The technology is moving very fast, and some patients use certain devices and stay on that one, but doesn't mean they need to stay on that one if the technology is moving. So keeping up to date, we ourselves, as well as updating our patients on those changes, on those advancements, is our duty, especially that in the future, artificial intelligence, multiple sensor technologies are coming together, and also much more accurate readings. And there are some hints that accuracy as down as a MARD of 5.3 may be coming to the market at some time in the not far future. Thank you very much for your attention, and I'm happy to take any questions you may have.
Thank you very much, Dr. Ali, for the incredibly insightful and practical lecture. Your expertise always actually giving us so much to take back to our clinic. I also want to extend another big thank for Sympionic to sponsoring for the third DAS Voice webinar and making this valuable education session possible. For the question, Dr. Ali, I think we will have a question and answer at the very end of this webinar. Both you and Ms. May will be able to answer all the questions, and we're happy to entertain their question as well.
Thank you.
So another message for the audience, please save the date between 31 of October and 1st of November. We are thrilled to announce that we will have the second Diabetes Endocrine Society conference will be held in Dubai, and please click the link to register and to save your seat. We wish to see you there, and a lot of activity and a lot of knowledge you will gain from that conference. And now we will also, if you have any kind of abstract, you can just click on the barcode and try to submit your abstract. You might be one of our speakers in that conference, which will be in the end of October. And just keep the barcode around and scan it, and think about abstract if you have it, and submit it as early as you can. And now we'll move for our second speaker. It's my distinct pleasure to introduce Ms. May Abu Jalal. Actually, she's one of my friends and colleagues. Ms. May is a highly accomplished senior diabetes educator with over 12 years of specialized clinical experience in United Arab Emirates. She holds master degree in public health, and she's an expert empowering patients across type 1 and type 2 diabetes and gestational diabetes as well. Throughout her career, working with major regional healthcare institutions, she has specialized heavily in advanced diabetes technology, including insulin pump and continuous glucose monitoring analysis. Please join us in giving very warm welcome to Ms. May Abu Jalal. May, the floor is yours.
Thank you very much. Okay, so today I will just follow Dr. Ali presentation. I will just re-emphasize more about the maximizing the use of continuous glucose monitor. I think we have the same vision about it. So what you cannot see, you cannot fix. Let's go further. Okay, so today I'm gonna take you through 3 cases scenario. Then after that, we will discuss them, what we did with them. Then after that, I will discuss with you why and how to maximize the use of continuous glucose monitor. Our first case, she's 50 years old patient with BMI 30.9, having A1C 12% for the last year. She's having about 12, 10, 9 moving around. Fasting glucose, as she claimed, between 150 to 180 milligram per deciliter on empagliflozin, metformin, and gliclazide 60 milligram once a day. Type 2 since 2021. She's having sedentary lifestyle. After seeing the physician and trying to convince her to start an insulin, as for a long time she's in high reading, she refused, and she's not convinced to take her own medication. This is the main reason. She was sent to my office to discuss with her the complication further and other things to help her to have better control. Usually people, I will assume, or this is what's going around, that we will try to ask her to do more blood tests, like finger prick, and she refused to do that. She refused the insulin. She refused even to increase the gliclazide to 120 milligram. So what I did that day, okay, I just sit there and talk to her, not about the complication because she knows them by heart. What I ask her, if she's willing to put a sensor. Then she was surprised that I'm not reinforcing the complication and you have to take medication, etc., because she knows that. So I asked her if she's willing to put the sensor, and let's see what's going on. Even the sensors I applied on, sometimes they give us a sample. So I apply a sample for her, and free sample. And I told her, if you don't like it after today, after 2 to 3 days, just remove it. It's a sticker and you can remove it. And actually I use this trick always, and it works for me with adult. So we put the sensor there, and you can see on her graph that the reading is high. Then after that, during that day, it starts to drop down. Also, you can see she blot some food down, which has helped her a lot in the journey of fixing her blood sugar. So the second picture, you can see she blot a lot of the meal time, and you can see some reading is high. While she was in my office, we check again what's going on. So we did it as specific to her. So you can see at 8:38 that time she had kaki. So it's date with the flour, and she was surprised that it increased her blood sugar that much, knowing that tamar or the date is not increasing the blood sugar. It's a healthy sugar. Moving forward, the same day after that, she had a juice, which is she claimed that it's there is no added sugar. So once we saw it, it's beetroot juice, and explained to her even without added sugar, the beetroot have sugar. That's why the blood sugar was increased. So blotting the food, it was helping her to identify the food which is make her blood sugar goes up, and what food did not make her sugar goes up. So it's personalized her diet plan. Moving forward, her fasting was 117 using the medication. So she started to use the medication. You can see even the line, the continuous glucose monitor, the line of it, the reading, it's getting flattened. This is her HP report. You can see she has 83% the reading within target, or between 72 and 80, and 13% it's above the 180, and 2 to 3% it's very high. We can see also that the GMI, it was 6.7, which is an amazing achievement done by her. Okay, and the variability was 29.8, which is mean that she's repeating the behavior correctly. Even she's using the sensor like 100%. What we learn in here. So fasting blood sugar did not tell us the whole story, did not tell us how the blood sugar was high after the meal and how it caused high reading after that. So she was just taking a snapshot in the morning for the for the fasting blood sugar, and that's it. And she was leaning to comfort herself by that reading. Long time above target, making the A1C going up, and repeating daytime patterns. So changing her food diet, okay, helping her to reduce her blood sugar. So we need to work rather than to intensify the treatment, okay, to let the people see the reading, okay, then take an action. So A1C, it will tell you there is problem, but the continuous glucose monitor will tell you where is it and why it's happened and if there is pattern. And I just want to mention something that A1C, it will show you retrospective, the reading, but continuous glucose monitor is showing you now and forward. Okay. The next case, our beautiful client, she's 37 years old with BMI 28.9, with A1C 6.7, type 2 diabetes, 10 weeks pregnant. And this is her first pregnancy after 20 years of marriage. So it was a precious baby. She's taking metformin 750 XR BID and on aspart 4 unit TID. What we can see from her reading that the finger prick, it was showing an amazing reading. Before meal, it's 95%, 95 milligram per deciliter. And after meal, it's usually 120, 110, 90 even. So the blood glucose was not reflecting the A1C correctly somehow. So what we did that time, we put for her a sensor. Unfortunately, she did not plot the diet, which would help a lot as it will personalize her meal, her treatment. So we can see some spike during this time, right? And you can see that we tighten her target and range 63 to 120. So you can modify that, as we all know, on the continuous glucose monitor to get the right percentage. Moving forward, some reading high. You can see there was high, start to go down somehow. And even here it's flattened. So you can see some increase, but it's flattened. So let's read her comparison because she's using the continuous glucose monitor since then. So the first 14 days, we can see there is low reading in the beginning. Okay, we can see it there, and it just subside on the next 14 days. So we can see an action was taken, okay, and take care of within 2 weeks. Then we have some spike afternoon, which is late lunch, and it just getting better, okay, within 2 weeks. She was having 87% within target. Then we moved to 93%. I'm sorry, I'm not seeing well. Okay, I think 93% within target. Moving forward, it was higher than 120. It was 10%. Then it got 5%, which will be a significant change for the baby health during pregnancy. So we can see the GMI move from 5.6 to 5.3. So if you will ask me, the A1C usually we indicate 1%, but this is a huge change during 2 weeks, which is usually will take longer time with the pregnancy to do that by finger prick. So pregnancy rule. So the average glucose is not enough for pregnancy. We are very tight with pregnancy for the sake of the baby growth. We care about post-meal spike, overnight pattern, which is happened here. It was low. We moved to better reading by reducing the insulin at the dinner time, okay, which is reflecting here. We reduce the hypo. Glycemic variability is very important because it will tell us if she's doing well or not, she's repeating the pattern or not, or we need to do a behavioral change. Avoiding hypoglycemia, which is very important for a pregnant lady for the growth of the baby brain. So continuous glucose monitor allow proactive adjustment instead of waiting for A1C, which will be for the next 3 months. I know in pregnancy we don't wait for 3 months or A1C, but continuous glucose monitor with the pregnancy can give us enlighten to see the reading and change on spot. Dr. Ali discussed this in details, but I have it already in the presentation. Time and range for diabetes in pregnancy. Type 1, again, they have should be within target between 63 to 140, 70%. For type 2 diabetes, it should be 80% and 90% for gestational diabetes. Moving forward, okay, so it will be 20 higher than 140. It should be it should be less than 25% in type 1, less than 15% in type 2, and 10% on gestational diabetes. Pregnancy require, again, tighter control and tighter interpretation. A1C, it's not the right matrix on pregnancy. Continuous glucose monitor help adjusting meal timing, the meal and timing of insulin dosing and follow up frequently. So the previous case, even she's type 2 with the pregnancy, okay, she was having her lunch very late. We move it forward and she was convinced to change her habit based on what she saw. Also, her reading was high. Sorry, I forgot to say that while reading the report. It was high. As I said, her A1C was 6.7, and after meal, she was 120 with the finger prick. So it was wrong? No. Her meal was very complex and having high fat diet. So the blood sugar was peaking after that. So what we saw as a spike, it was after the meal, 3 to 4 hours. So she learned then, okay, to reduce the oil and fat in her food and to adjust her food based on what she saw. So by just having continuous glucose monitor, we could be able to see the spike, which could not be catched by finger prick. Also, it's not to collect more data. It's about how to utilize them to serve the patient. We don't want to overwhelm them, which is I will speak about in a bit. Our third case, she is a 30 years old client with BMI 24.2%. As she lost her weight, she was overweight as she had a history of PCOS, and the doctor told her she need to lose weight to get rid of it. Having history of GDM with family history of DM and blood pressure. She's not on any medication. The A1C she came with, it was 5%, and arrived with a complaint of dizziness, fatigue, and loss of consciousness. She saw neurology and ENT doctor, and both of them cleared her out. So when she arrived, she was always complaining that her mom did not take care of her while she was a kid, and she was always fainting in the school, and she will never be returned the awaken or the conscious without having some sugar. Saying that, the husband said that she was falling down and lose the consciousness. Then he called twice the emergency. The ambulance came in, the paramedic came in, they check her blood sugar. There is no low blood sugar. And he said when she's flattened on the floor and her leg up, then she get her conscious back. However, the paramedic said her blood pressure was normal. And she keep complaining that she needs sugar all the time. So test was run. We did fasting glucose was 90 milligram. We did OGTT, which was normal. We did cortisol level was normal. And HUMA IR test was also normal. Saying that with the number which is mentioned on the screen, okay, for what she's feeling, okay, it was not satisfied enough. So we were thinking how to convince her it's not diabetes, and also to see all the tools that we can use. So we put for her a sensor. The first day it was some reading low, but ignore it. While she checking with the continuous with the blood, it was normal. So it was not a real hypo. Then we can see the reading, they are within target. She was pointing the meal. They were fine. They were up a little bit to the edge, which is fine. It's a 140, the target. So the reading was fine. And we can see her HB report. That was 97% within target, 1% high, 1% low, which is not really low. So the GMI was 5.7 and the variability was 12.7, which is great. The average glucose was 102, which is great also. By seeing that by her eyes, okay, it let her stop somehow during this process. So how we respond or what we did with her. So we learned that the continuous glucose monitor, not only for diabetic, it's not only to show diabetic people what's going on wrong, sometimes just to tell them there is nothing wrong, okay, with her data. So we told her, okay, she doesn't need to be anxious about diabetes on that, okay, and we told her with all the tests was run, plus the continuous glucose monitor, it's out of diabetes zone. So better to see more physician to check her case and to know better what to do and how to tackle it. We refer her again to a neurologist to evaluate her and by our end in Burjil to see if he can do anything else. So we can justify things not only for diabetic, for non-diabetic also. Visualization. So I believe in this a lot. People with experimental theory that if you do or you see, okay, then after that you will change the behavior and you will adjust your behavior. So adults, especially when they see there is a problem, they try to fix it. But if you will tell them you have a problem and point it out for them, usually they don't listen. So let them see. The whole point of continuous glucose monitor from my end to a diabetic patient who's refusing to change their behavior, it's a trick and a great tool to change it. And I can see with almost of all the clients, okay, he's using continuous glucose monitor. I leave them with the 3 days. Even sometimes the physician will tell me, call them. We need to know why the blood sugar is high. Okay. And we need to help them more. Okay. I just give them the rule of 3 days. After 3 days, I see the spike goes down because people by default change their behavior unless, if they're having a depression which is part of the process to go through any long-term disease. So if they are down, they will not change their behavior, even if they see something. But usually people, they turn to change their behavior if they see there is a problem can happen. So self-regulation theory, when people receive feedback about their performance, they compare it to the standard and change their behavior. So it gives them a push to do the thing on the right time. So they are proactive rather than waiting for us to tell them they're reading high. Then you will tell me, yeah, but they can do that with the blood glucose check. They can do that, but they cannot see the whole image or the whole vision of the reading. And people nowadays, even when they come to do the continuous glucose monitor, they want to know how they're reading after the lunchtime, which is they cannot do it in the office, right? And even in the school. Sorry. Okay. So the benefits of evidence supporting continuous glucose monitor, key benefits of continuous glucose monitor, improve time and range. So once people, they see the reading and how the sugar it's increasing, or what the food it's increasing, or how their sleep doesn't serve, less hour of sleep will make their blood sugar goes up, or if they, when they exercise, they can see on spot the blood sugar drop down. Okay, they tend to change their behavior and increase the target and range. So once the target and range increase, it pushed the A1C to be in better shape. And they found out once you have 70% of a target and range, usually people, they get 7% as A1C. Also, we improve the patient engagement rather than to be me telling them what to do. It will be them finding the problem and try to fix it with our help. That's why our role is empowering people and try to guide them to the right track. So we need to give them the tool to be able to change their behavior and to change their way of dealing with diabetes and the lifestyle they are carrying on in their life. Also, by seeing the hypoglycemia and the hyperglycemia, and not ignoring the rule of hypoglycemia in each diabetic patient day, how it affected, and the hypoglycemia is way worse in their experience than hyperglycemia. So they can detect it earlier, because with the alarm system, they can tell if they are going with the hypoglycemia. Also, the continuous glucose monitor will help us to build up with the people, as you all know, hypoglycemia and awareness, to build it up back if it's possible, like to put their target rather than 70, it will be 80 or 90 based on their severity and the discussion with the physician. Okay, and we let them correct it. Then the body will start to learn that they have low blood sugar and increase the alarm back to 70, which is a great tool to be done by the continuous glucose monitor. So maximizing the use of continuous glucose monitor. Continuous glucose monitor technology is no longer just for insulin management, which is, I will always be advocate about this part, because we are missing a huge part of people who can use the continuous glucose monitor and be benefit of it. And they are the upcoming type 2 diabetes. So people who's having a problem with the sensitivity, insulin sensitivity, and pre-diabetic, they are upcoming type 2 diabetes. So rather than to welcome them to the group with the continuous glucose monitor, with the treatment after they got type 2 diabetes, let's stop them and let's them go back to normal or the gray area. So nowadays, it's a valuable tool to across the spectrum of metabolic health. So continuous glucose monitor empower individual to understand how daily choices after glucose level in real time. So rather than to see that ice cream, how it increased my blood sugar, which is, it will be blind with the finger prick, it will be I can visualize it, okay, with a continuous glucose monitor. So I can see it and stop that behavior or change the way. So people, rather than sometime you eat something, then the blood sugar will spike. We ask them to change the sequences of the food they are eating, like protein first, then vegetable, then the rice. And it will help a lot on reducing the spike of the blood sugar. So they can do trial and error and know what's benefit for them. Because I can tell you right now, for sure, 1/3 of a cooked cup of rice, okay, equal to half Lebanese bread, which is, it will be 15-15. This is what we know as knowledge. But what we witness with the people, sometimes they will come and tell you, I take a plate of rice, nothing happened. But when I eat little bit of bread, it shoot up. So this will individualize the treatment to the patient and the client, and they will understand better. And this work a huge effort with pre-diabetic and insulin sensitivity people. It worked with them a lot. So once we put the sensor, they start to track what food make their blood sugar spike, and they reduce it. So we don't utilize the pancreas quicker, okay, and request more insulin. And this will improve the insulin sensitivity for them. Knowledge of glucose trend enable better decision making and greater confidence in diabetes self-management. Rather than they will go back home and they will think, shall I reduce my insulin? They can reduce it because we teach them. They can reduce it. Then after that, they will see how the thing happened during the day or during that meal or with that meal. So let's say I'm eating every day, I'm eating biryani on lunch, which is not the good choice. Okay, but I'm eating biryani on lunch and I'm having 10 units with it. Always I drop down. But while I'm eating other things, it works well. So now I can see with biryani, if I make it 8 units, how it will help me. So we will go in details of the details to help them to be in better control as their tolerance. Okay, because some people, they will be overwhelmed with this kind of information, but we can build it up through the sessions with them. Small adjustment guided by continuous glucose monitor can lead to significant improvement in glucose control. I always think that small steps can help to the better achievement with the stable achievement. Some people, they will jump with their treatment, or they will jump with their, okay, I will stop everything. I will not eat this and that. Okay, then they will go back. Small steps help to, with rationale, help them to take it further and stay with it and to improve their blood sugar slowly. So the barrier to continuous glucose monitor, there is no doubt there is always barrier. So we are not on the heaven. So the cost and insurance barrier. Cost and insurance barrier, it's a big burden on people because nobody wants to spend about 200 plus on sensor, which is 14-15 days. And it's not, hopefully it will not be a lifetime. Hopefully they will find solution for it, but it's for a bit longer time, which is a long-term disease. So usually to overcome this cost issue, the companies, sometimes they give us a free sample, which is we use it. The other part also that there is some voucher will be given or have price on another area. So I always follow up the how to help them better with the less price. Also cost and insurance barrier. People, if they don't understand how it will help them, they don't want to spend money on. So if I don't know how you will serve me, I will not spend money. And you cannot that if you check when they come to you the first time and they have to pay the amount of money, the non-thiqa, and they will come and they feel sad in the beginning of the session. Then by the end of the session, they are grateful to see you because they know now why they have been instructed to see you, and they will come back. So what I do with them, I give them the free sensor, okay, and let them try it and compare it with the blood for sure, and try it and see, maximize the use of it, okay. Then usually they buy it again. So what they think it's beneficial for them, okay, they will use it. Actually, sometimes we go out for a dinner or go outside, we pay more than this money, but I will not pay it until I understand why I have to use it. Physical discomfort, some people, they don't want the thing to be stick on their body, which is totally understood. Always find a way to do that. So I just take the burden off them. I will tell them, I will put the sensor, let's try it. Okay. If you feel you are not happy to use it, take it off. Okay. And luckily people, they don't do that more often, except my mom. Device fatigue, so emotional burden and data overload. So usually people, some people, they don't want to see the reading. They don't want to see the truth. They maybe under anger stage, or they are on denial stage. I don't want to see it. You want me to take the medication? I will take it, but I will not see it. We have to understand the limitation we are with our clients or our patient, okay, and maneuver around it. So once the patient trusts you, they will tend to try the things you will advise them with. Find the strong caregiver among us, like maybe they trust the dietitian, or they trust the physician, or they trust me, or they trust the nurse or physician. So we will find the stronger person between us, okay, to maneuver around that and help them with that. Data overload and anxiety, I always tell them, take it as experiment. That reading was there. If your A1C is 12, that reading was there for a long time. So you just now have a glasses seeing what was going on. You don't have, like, you now just see it. It was there. So don't worry. It will not cause any harm right now, okay? But it might later on. That's why we need to see, to tackle what's the problem and to solve it well. So practical approach for diabetes educator. I know all of us, we do our best to find, to serve the patient in a better way. My advice only, because this is, I saw it many times, while choosing the right sensor for them based on their need, comfort, and literacy. So while assessing the patient, because I noticed that sensor was written like instant, okay, I will choose this or that, okay, get the sensor and come back, we will apply it for you. Okay, this is my observation to some people, okay? So what I noticed, if you assess the patient well, for the right sensor, okay, we will have better achievement and better use of that sensor. So if your patient, let's say elderly, and he don't want to check, make sure that the sensor you are using is a scan barcode, okay, and usually they come to the clinic. We scan it and that's it. Make sure that the sensor is collecting the data even if the patient is not close. Last week I have a client who came, he don't want to download the sensor app on his mobile because he's an American app store. So we downloaded, and his wife agreed to move it later on to his other mobile. Long story short, it did not happen. So he was on my office. I'm trying to download the reading. Then I told him I cannot see anything, which is keep mentioning it's 10 days. Then after that, he said, I don't know why it's not there. We went to the wife. He was standing next to the wife. The Bluetooth work, okay, it came all data. So make sure that the client who doesn't keep the mobile next to them, they have a sensor that can catch up the data, whole data, without needing to be very close to all the time. Try always choose the sensor which is need to be very sensitive. If you have a hypoglycemic patient, make sure that that sensor doesn't have a default of hypoglycemia, like they have a lot of hypoglycemia there. So just always try to find the right patient to the right sensor. Maybe he don't want the alarm. Change the tune of the alarm, because a lot of them, they switch off the alarm because they don't like the tune, but we can change the tune of the alarm. If he is she's 12, the one who was 12 A1C, I switch off the high alarm. Then we agreed we will open it later on, which is we did. Okay, so just understand your patient better and how to serve them better, okay, by doing the right assessment. Who can be beneficial of the sensor? Okay, pre-diabetic, as I mentioned earlier, pregnancy. So if your client, be proactive, always be proactive, think out of the box. The way I think about it. So pre-diabetes was having pregnancy or insulin sensitivity with the pregnancy. So they usually tend to have some high reading around. So if they are caring a lot, by knowing themselves they are pre-diabetic and they want to take care of that, put sensor, and we will see the reading how it goes up. Obesity with weight management and GLP-1. Actually, it was run a study. People who's having GLP-1 without sensor and people who is having GLP-1 with sensor. The people who's having GLP-1 with sensor, they lost the weight higher than the people who just have the GLP-1. Why? Because they were proactive about their action. They saw the exercise, how it helped them. They saw the food glycemic spike, or the spike of the food, how it goes up, and they changed their behavior on spot. That's why it was better weight loss and better behavioral change. Again, insulin resistant, they might put it. Certain glycogen storage disease, and which is cause frequent low blood sugar, and there is 19 type of them. They are rare diseases, but they can be beneficial of it. Post-bariatric surgery, which is we do a lot in our clinic. People usually will start to drop their blood sugar after bariatric. They will go everywhere. Then they come back to us as endocrine. Then we put them on the sensor, make their low blood sugar on 80 or 90, how their spike low goes. So we target 80 or 90. Once he reached 90, he need to take complex carb, which is 15 gram of complex carb, rather than to go low. Once they go low, they will be an endless circle of low correction with the quick sugar, then low and correction with the quick sugar. And it was changing even their behavior. I have some patient, they correct their hypoglycemia, like they will have it now once in a week or twice in a week maximum, though it was daily, and they changed the way they eat because they found out once the food spike with the blood sugar, then the drop, it will be very heavy. Then we change even the sequences of the food, as I mentioned earlier, protein, then veggie, then the carb. Real-time feedback on food, exercise, and sleep. It will change their behavior, especially the sleep, because nobody listen. Recently, we attended the session of Ms. Fatten on the Imperial College Conference for Diabetes Educator. She mentioned she mentioned something nice. Now I forget it. I believe she mentioned about how they change their behavior. I'm sorry, it's get out of mind. How changing the sequences of the food and how change their behavior will help them. Encounter healthier behavior and better adherence to recommendation. So now they will trust you once you give them that and help them. They will trust you better. And while discussing, rather than I will tell them that your blood sugar is high, we have to increase the increase the food, the insulin, or increase the medication, we can by reading their reading and see the food they use, okay, and how it interact, or the exercise, how it interact, they will take the small advice and use it and see if it's work or not, because their decision right now. Enhance patient engagement, as mentioned earlier, and self-management. Enable personalized data-driven discussion with a healthcare provider. So once you have a plan for them, okay, and show them what they can be beneficial from that action, then after that they are willing to change and willing to take the next step with you. My message for today: keep it as simple as you can. Assess them well, use the right sensor after the assessment. Always advise the patient to check and co-check with the blood, not only with the just to rely on the sensor, because we know sensor, it's an interstitial fluid, it's not a real blood. Hopefully what Dr. Ali mentioned earlier, that it will be in the blood directly, then after that we can rely on. And maximize the use of it. Let's give them the tool to help them to be better by their will, not by the reinforcement of education. And I found out once people, they know their things, or how the things going around and how their life run around by the continuous glucose monitor, they lean to ask more questions to change their behavior rather than to be telling them what to do. Thank you.
For the outstanding presentation and for sharing those highly practical clinical insight. And just one quick message for our respectful audience. Please know that this webinar is fully CME accredited, and we will be sending your certificate starting from tomorrow by the register email that you register to attend this webinar. And please make sure that to check your email and notify us if you haven't received your certificate. And now we're going to for the third session, which is question and answer. And we will invite both Dr. Ali and Ms. May back to screen to answer your questions. And please let us dive in first question. So, one candidate asked about the hypoglycemia regarding an self-monitoring blood glucose monitoring system is used to check for the false CGM readings. If the patient have no symptoms, specifically early CGM application, do the patient need to check in blood, or just they need to rely on the CGM?
So I would say don't take any chances. If the sensor is showing low, you need to check, especially if there is a hypoglycemia awareness impairment. But like either ways, confirm, especially like the first and last day of the sensor. Some sensors are less accurate in those days. So confirm with the finger prick, be safe. At the end of the day, we are talking safety here. And if it is normal, it's okay. Some sensors you can calibrate. You can add a calibration to help, the sensor become more accurate and sensible. But there's no harm in doing that. In fact, it is certainly advocated.
Thank you, Dr. Ali. So maybe question, I think this for Ms. May. One audience asked about how much it's important to sensor site rotation when we replace the sensor. Is it really need to be rotated every time since there is no medication inside the sensor, or the people can just have one or two peripheral site and they keep using it over and over?
Okay, I believe that we have different sensor and we have different site of the sensor. Like Dexcom, you can use it in many areas, but Libre, Sibionic, we can use them only on the arm. Okay, I will go with change the site always, because this is an insertion which can cause sometime like trauma to the area. So we need this area to be relaxed, and especially sometimes the sticky part part can be causing some irritation. So we need to move. Even if the patient like one arm, let's say, it should be 4 finger, right? Then from the elbow, then after that, we can use that part. Okay, we can move around that area. Okay, then we can move to the other arm. Some people, they will tell you, no, I sleep on this arm. I don't want to use the other arm. We should just to re-emphasize, it's okay, no problem. You can sleep over it. There is no needle, etc. And the elastic part, we should make sure that under it, because I hear that a lot, shave if the hair is a lot. If they have a lot of hair, make sure that you shave, clean well. Then after that, usually I advise my patient even to clean before 1 day, so they don't have any injury on the skin, which is we cannot see it. Then clean it well, then apply. Always change the side. Even it can be in the same arm, but change the side around. It should be.
Okay. So, Ms. May, so what about if the patient decide to use the site where they have hyperliber atrophy because they can't take insulin there? Do they can apply the sensor there instead?
You mean if they can apply on lipohyperatrophy?
Around it, yes.
Okay, we should assess the area. Okay, if the area clean, we know the lipohyperatrophy, you can assess it and find it. Then around it, the clean skin or the clean tissue, you can apply the sensor around it, but not on the lipohyperatrophy, because even while not checking the area for the patient, even in the beginning, some people, they will start to put the sensor on the lipohyperatrophy area. So it should be identified to the patient, because they will come and tell you, no, the sensor is not accurate. It's not true. It will be the area which is not identified well. And sometimes, unfortunately, we miss it, either because we are busy or assessment was not done,
I can't agree.
or we are so naive to the lipohyperatrophy areas.
I can't agree more with you, May. Yes, I agree with you. Okay, so another question, I think it goes for Dr. Ali. So the question is about a difference between CGM and self-monitoring blood glucose monitoring system in pregnancy for those patients who always forget to check. The question is for a pregnant patient who frequently forget whether or not she has recently eaten, which is clinically superior, CMPG or CGM? For a practical standpoint, SMPG is often preferred during pregnancy. What does clinical evidence suggest?
So this is a very interesting question, and I mean, the clinical evidence is there. Like, we have stronger evidence for self-monitor blood glucose, but if the lady is forgetting whether she had food or not, I think the mental state of kind of concentrating on her diabetes is not as much as kind of going through the glucose meters and things. So from a practical standpoint, I would say, here CGM is more superior, because it will have the record of those glucose readings before, during, and after her food. If she had food, and, she will see like the spike of her glucose if she had food. And if she's not had food, she will know what happened. So CGM here practically is better. This is, I hope that I've answered this particular point, but blood glucose monitoring, self-monitored blood glucose readings are more accurate. There is more evidence for it in general. But for the points that May mentioned, I've mentioned, the data that you will get from the sensor is far, far superior.
100%. And that participant asked about what if the patient does not remember when she eats? And again, I think CGM, it will be the best, because we can know from the spike of the glucose when she eats. If she couldn't remember, then she will not do the CMPG, but the data will be in the CGM instead.
Correct.
Can I add one more?
Yes, please.
I ask them, rather than to remember when they eat and to blot it, I ask them, just show me what did you eat. So usually I ask them, just take a picture. Let's analyze what you ate, okay? Rather than asking her to blot it before what she ate. So they use, by changing the concept of let me know when did you eat, okay? Just take a picture. Once they take a picture, and I use this with the pregnancy woman, okay? Then after that, when she come, we will be talking about the food, and you will find tremendous information with the picture, which is will tell you why her blood sugar is high.
Yeah, I agree with you, May. Thank you. So another question, I think this goes both for Dr. Ali and Ms. May. It's about tracking meals and data accuracy. The question is, when a patient cannot really remember their meal time, what education strategy or devices feature can help ensure accurate data interpretation for both CGM and CMBG?
Interesting. So, I mean, if I understood the question correctly, is what strategies can these technologies can enable, or what is the utility of those technologies in enabling patients to monitor their glucose in response to the meals and whether they took their meals or not?
Or what's the device features that can interpret both CGM and SMBG? I think her question is about how we can motivate patients to record their meals in timely manner. Because when we give them like a food diary, sometimes they don't record and sometimes they do. And we know that we can add the CGM. Then if you can add the point like a note, and you can write whatever you are eating.
I agree with May's advice actually, because
Picture.
picture, I mean, basically life happens, it's not always easy to write and document everything. It's good practice. We always encourage it and we really like it because it gives tons of information, but just take a picture. That's better than just leaving things. And also alarms. I know alarm fatigue is bad, and we try to minimize it as much as possible, but if someone forgot to document their meal, or they ate and without kind of recognizing that it was significant, the alarm of spiking sugar will bring that home, and then they can troubleshoot from there. And reflecting on that, especially from the portals, and I believe all the CGM companies have portals that we have as healthcare professionals have access to. We can also troubleshoot those kind of patterns as well. I don't know if you have anything else, May, to add.
Thank you, Dr. Ali. Also, I tell them, if you take a picture, okay, that we will get rid of after 2 hours to see. So once you take the picture, it will come analysis that it will show you. Once you take the picture, it will show you after 1 hour of how much the blood sugar was, after 2 hours how much the blood sugar was, and it will show you the highest reading between them. So rather than to do the job, it will do the analysis for you. So usually I'll tell them, just take a picture and let's see what you are eating. And once you sit with them the next visit and discuss the food they have been eating, okay, and how I had a Moroccan beautiful pregnant lady. She was, what did you eat? Meat. Okay, let's break it down. She took picture, luckily. Okay, it's full of olive oil. Lovely, okay? But the olive oil with that meat, okay, and little bit of rice, it spike her blood sugar like hell. Without seeing that by a picture, okay, I will never know. And because she believed how the way she say it, I take only meat. So even if she would write it down, she would write meat and little bit rice.
Yeah.
I love to use the maximum of the sensor ability.
Yeah, 100%. Usually we ask them just to add note in the platform itself, or just write it in a diary and bring it along with them to the clinic. It's very helpful.
True.
Okay, there's another question. The question is about the imaging safety, like MRI and CT scan protocol. The question is, it is medically mandatory to remove the CGM sensor before a patient undergoes an MRI or CT scan?
Yes, I think MRI, it's not safe. A CT scan will damage the sensor probably. So I think my understanding, some of the companies are working on MRI safe sensors. I don't think they are available yet. And the sensor may, like, especially in the MRI, there's no chance, because if it is pulled out of the arm, it may hurt the patient and it may cause trouble to the scan. So it's better to remove it. And as we know, X-ray ionizing kind of radiation can damage the circuit. So the sensor reading may not be accurate anymore. So that's why sometimes, like even in airports, we tell the patients, try to avoid the X-ray and make sure that the sensor is accurate after you go through the X-ray. Sometimes, like, the X-ray can damage the skin, and the CT scan is X-ray based.
I think the reason behind this question is because now we know most of the healthcare insurance, they don't sponsor those sensor. If they apply it like for 2 to 3 days, then they have CT scan. They have difficulty to get another sensor, and I don't know if the company willing to replace those sensor or no. So maybe the question because of this point of view. But I do agree with you. But it is new to me that if the sensor goes through the airport gate, that might affect. Usually we do that with insulin pump, but it's really good that if we can just give them a certificate, like medical report, that they cannot go through the X-ray and they go for manual checking, like wise what we are doing with insulin pump.
Yeah, I mean, that doesn't happen all the time, but if it happens, it may danger the patient, because they will rely on a falsely reading sensor. So it's scary. Yeah, they either need to confirm it is still working, or they avoid the X-ray in the first place.
Okay.
And actually, also speaking to companies to replace the sensors, usually companies are very kind. They give us like free samples, and I don't think it is a major issue if there is an MRI or a CT scan for the patients, or for us to ask the companies for for a sample replacement.
Yeah. So we have another question, I think, for May. Is measuring blood pressure is allowed over the arm which has the sensor?
We don't advise that, no. Why you have to cause trauma over that area? If that patient having high blood pressure, it goes to 200 plus, come on. No.
Yeah. So we have another interesting question by Mr. Maher. He asked if patient has time in range 97%, but his finger blood glucose is like around 112 and fluctuating in short while 227, so between 212 and 227, then to 140, then back to 129. Is this variability in finger break harmful, or it's result for liver glucogenesis, as type 2 diabetes has insulin resistance? What is your consideration fluctuation blood glucose and excellent time in range?
So this is an interesting point, actually. So humans without diabetes have variability. We don't have like an only one line. And I think the human variability ranges between, in normal health, is between 8 and 12%. It varies, obviously, depending on the food we take, and like teenagers, for example, it goes higher because they go 4 hours without food, they exercise, and then they may have like a big meal. But
just Dr. Ali, just to correct his question, he asked about the fasting, not finger, sorry, fasting blood glucose.
Fasting.
My mistake, yeah.
Okay, so if fasting glucose is high, then all over the night it will have a damaging effect on the blood vessels. We know this. This is not very high fasting glucose, but nevertheless it's not normal. So here, it's not the variability; it's the fasting glucose. What could be kind of what is suboptimal? Obviously, the situation is important. For example, if this is an elderly patient, I would say amazing job. If it is a young person or a pregnant lady, this is a bad one. So it's context based. At the end of the day, time in range is 70 to 180. It's not time in tight range. And even at time in tight range, it does not reflect that particular point about fasting glucose. So those measures still are important. the fasting glucose being good, and it may reflect the gluconeogenesis, obviously, as you've rightly mentioned. It may reflect late meals. It may reflect gastroparesis, sometimes with delayed absorption of food. There are different potential causes for it. Obviously, it needs to be troubleshooting need to be done, and studies need to be there. But high basal glucose readings are not benign, so that need to be taken into consideration. And that's why, not only like a time and range is important. Everything is important. We look at the patient holistically, not only a single figure.
Okay, and we have another question for you as well. They ask about how valuable are the CGM sensor and the diagnostic algorithm for suspected insulinemia? Do you find them effective in reducing the diagnostic uncertainty during the fasting test, or the limitation is using them for a specific purpose?
For hyperinsulinemia, you mean? Like for hypoglycemia, recurrent hypoglycemia?
I think he meant hyperinsulinemia, yes, but he didn't mention, yeah.
So, I mean, if I understood it correctly, like, the likes of dumping syndrome or like insulinoma risk, in general, if you look at all the sensors, they lose accuracy at lower readings. And that's why you see, like, which I prepared it, but I didn't show it today because I didn't want to go to those kind of technicalities. The ISO standards and FDA standards for CGM and glucose meters is how accurate it is at low readings and how accurate it is at high readings. And majority of centers start to lose accuracy at low readings. So, and that is kind of the clinical question there. I don't think it has been validated for that. To my understanding, the highest accuracy for low readings goes from the fluorescent technology, which is like Eversense, which we don't have here. Good enough, but I don't think you can rely on it for diagnosis. In those cases, we admit patients and we do finger prick in a glucose meter in the hospital, which has higher reading than the home monitors that we have. And then when it hits that target, we send it to the lab to get a biochemistry reading of the glucose.
Thank you. And question, I think this is for May. What acceptable difference between self-monitoring and CGM?
Okay. If we will look not only for the reading which is shows on the screen, also we have to look where is the arrows going. So if straight up, straight down, okay, the variability will be high, okay, and this is limitation of the sensor, which would be acceptable, and we have to take an action based on the blood glucose. Okay, as it's a limitation of the sensor. However, if the arrows going slight little bit up or down or straight, I will go with the 20%. Plus minus.
Plus minus. Okay. We have another question. What the difference between HbA1c and GMI? Do we rely on GMI, or just we need to keep doing the HbA1c every 3 months?
So I really like this question. GMI is practically a formula based on average glucose. So it's practically you look at the average glucose and you apply the formula and you get the GMI. But the way I look at it and I tell my patients, your HbA1c tells us how did your sugar behave over the past 3 months. Very clear, like 2 to 3 months, depending on their hematopoiesis and so on. But their GMI tells us how's their glucose faring like that, and their HbA1c will be like that if they keep that control for 3 months. So it's kind of predicting the future. HbA1c is telling us about the past. So this is how I put it forward to patients, but they are not exactly the same.
Exactly, they're not the same. Yeah, absolutely. So we have a very tricky question. I don't know who going to answer. How and what factor parameter do you look to decide which sensor is needed?
It's a tricky question.
Very tricky, yes, I agree.
So the way I would look at it is like this. If you wanted to connect to an insulin pump, then it should have that capability. And at the moment we have, like with Omnipod, we have Dexcom G7, G6, and Freestyle Libre 2 Plus here in the region. And I think, Freestyle Libre 3 Plus is coming. If you want it for predicting hypoglycemia for the night, for example. Like if you want the AI algorithm, the predictive algorithm, you go for maybe Roche Acute Check Guide. If you want like a reliable, easy to use, very simple sensor, all of them do the trick, and Sibionic is probably the most affordable and easily accessible one, and it's user friendly. It's not geographically locked. They can get it. They can use their like app store from US or from Mozambique. It doesn't matter. So at the end of the day, the patient also tolerance, and if they have like an allergy from one, you have to move to the other. But in general, we are really lucky to have all those devices available at our disposal. And I don't think there is a major difference between them, apart from those little nuances that I've mentioned. I don't know, May, what are your thoughts?
Just to add, sorry, may to interrupt. Just to add, sometimes just we end up for one sensor because the patient mobile does not support another sensor. It happened with me
Yes.
multiple times. So the device support this sensor, so we go for what patient have. So it's really vary between patient and the other.
Very true.
Okay, May, do you have any thought about that?
No, I explained in the presentation. Okay, I will go maximize the use of the sensor while giving the right patient the right sensor. So just study the case well, okay, and decide based on that.
Okay, so I think we have one question asking about the people with AV fistula. So, if patient have fistula, they can't have a sensor in that hand, and they don't have lower leg. She mentioned it's lower leg blood pressure is not accurate. So the question is about safety is needed. Does it will affect data safety or no? I didn't the question exactly, but I think she asked if the patient have AV fistula for dialysis. So have we only the other upper arm to check? Lower leg blood glucose, blood pressure is not accurate. So question about safety is needed. Does it will affect data safety or no?
So my answer to that is pragmatic. So the side where the fistula is there, certainly it's a no-no. That's kind of out. So the other arm we have to use, and if the skin is not is too raw or we cannot use it, then maybe we can use the tummy, but we need to confirm with the finger prick. It's off license. This is important to mention that because these sensors have been licensed on the arm. I think the only one that has been censored on the accepted on the tummy is G6, Dexcom G6. And yes, blood pressure in the leg may be not accurate, especially in people with dialysis, because generally speaking, they would have vascular disease, and there is this stiffness, and there is so on. Another layer to it in general in people on dialysis is the accuracy of the sensor may be affected by the elutes and their dialysis and their hyperuricemia and their like high creatinine. So it's really difficult in those cases, particular cases. It would be worth, and I highly recommend it, validating this and putting two sensors, one on the tummy and one on the arm, and comparing them, because eventually you need to use another site other than the arm without a fistula.
Okay, I think last question. So Dr. Ali and Miss May, you know that nowadays we are very busy in our clinic. So when patient walking with weeks of continuous data, how long do you practically spend reviewing their CGM report to make a decision and clinically change? And what are the key metrics that you glance at first to get the immediate snapshot?
Okay. I would answer this quickly because this will reflect what we see in the clinic, but may probably have, usually you spend more time with patients because that's kind of by default how you do. I look at the CGM because that will give you a very quick snapshot of a summary of what has been going on. First, I ask the patients, has there been any events that you want us to look at? Because, that's kind of an important one. We go to that event, we troubleshoot it, we look at it from whatever treatment they did, whatever food they did, whatever, so on and so forth. But if we look at the AGM, that will give us a very quick snapshot about how things have been going on from a variability point of view, time in range, from sensor use, accurate use of it, and so on. And very quickly, we look at the figures of time in range and variability, and average glucose and GMI. Those are very quick. It takes 2 to 3 minutes, and you get it. You get it clearly. And then ask the patient about those events that you want to troubleshoot. This is my approach. Obviously, if we have time, I go through the details, but sometimes it's not practical.
Yeah, I do agree. It's based on how the clinic volume you have. Sometimes it's really massive.
Yes.
And I want just to mention, if this is a question from somebody who's new as diabetes educator, I promise you, you will be quicker, like 1 minute, 2 minutes it will take maximum. Because once you read a lot of them, okay, you will be able to you can see it, you can just point it out, but more investigation rather than just to give it's here, okay? So we will know better. For me, variability, it's a key point. Because if the variability is huge, come on, let's start basic education, okay, and find out what's going on. Maybe he's having night shift and day shift. That's why maybe the variability is high. So it depends on each case by case, okay, and how you read it. But variability, the first look I look at variability. So I need to know what to approach with them. But if this is a new educator, I promise you the thing will be easy, as well as the insulin pump, how you read it. Because I know, Shakir, we all read insulin pump, and nowadays we read it very quickly. But before it took us like 1 hour to read it. So things will be easier. You will find your way to read through it, because everybody's having different mapping and observation. And this is the beauty of different people, because whatever I can catch, maybe the doctor can catch something else. Then we complete the story.
100%.
My suggestion, and I don't know if Zainab, you are still with us, maybe workshops on how to read in a busy clinic. Bring a lot of kind of examples and go through it, and that will build the skill. It's very important not to miss anything. I mean, we don't want to be quick and miss like valuable insights, but it only comes with practice. As May mentioned, the more you see, the more you'll be able skilled in it. And maybe a workshop like focused on that for those who need it will be practically advisable.
Yes, I do agree. Thank you very much, both of you, Dr. Ali and Ms. May. And as we came to the end of our today session, I want really to thank from my bottom of heart and give a massive thank you for both of our exceptional speaker, Dr. Ali and Ms. May, for sharing their invaluable insight with us today. We are absolutely thrilled also to celebrate the success of the third Diabetes Educator Society voice webinar. Today we welcome fantastic audience of almost like 200 when I saw the audience, with many new members joining our community on board. Thank you all for your incredible engagement and time and question that you posted in the question and answer. And one final thing, please don't forget to register to follow the Diabetes Educator Society in our social media platform to stay connected. So we also highly encourage you to register for the upcoming conference that's coming in the end of October. And you have groundbreaking research. Please submit your abstract soon, so you might be our next speaker in the conference. And to make things easy for everyone, we'll be sending an email for the register email that you use today to attend our webinar, starting from tomorrow, that have your CMA certificate along with all the direct links for our conference registration, abstract submission, and social media channel. Hopefully, we'll see you very soon on the fourth Diabetes Educator Society Voice webinar. Stay tuned and keep an eye on your register link, and keep an eye on your email. And final big thank for the sponsor for this today activity and sharing information between all of us and getting to know each other for Sympionic. Thank you indeed.